Morning all. Sit over. Yeah, I'll just let the panel assemble a second. Hope everyone's doing well today. It's great to be here back in Manchester. I trained in Manchester a long time ago, which was excellent. Hands up, who's from Salford in the room? A few. Hands up, who's from MMU? The far superior university in Manchester. Excellent. I'm going to start off. I've got 10 minutes before we go to the panel and start the discussion. And I just want to focus us in on what the collective problem is. And I don't just mean for physiotherapy, I mean broadly in healthcare. So Wes Streeting, as the Health Secretary, what's he in his office worrying about at the moment? What's the system worried about? And where should we be concentrating our efforts? So, if the button works. So, if we look here, we have a significantly aging population. So if you look at the grey box there, particularly the one at the bottom here, when the NHS was set up in 1948, there was 1.5 million people over the age of 75. Now it's 5.2 million. There's been a significant shift in how the system is dealing with patients and demographics. So this is another representation. You can see male and female there, and you can see the graph in 2021 there on the right is much bigger at the top. We've got a significant shift of an elderly population that the system is having to deal with, and that is only going to increase. So if we look at the latter bars here, and the top blue bar is over 85s. So what we've seen in the last 60, 70 years in over 75s, we're going to see in over 85s in the next 40 years. So you can see there, 2041, 2066. By 2066, 7% of the population will be over 85, not just over 75. That's going to be a significant burden for the system. And we know as you age, health deteriorates, and we can see here that over time, so this is 2019, so this is pre-COVID as well, that although healthy years lived has increased, the blue bar at the bottom, so has years lived with disability or ill health. So as we age, we are getting more years in ill health. So we're not just aging, but we're also having deterioration in health. Location matters. So we can see sunny Manchester on the right there, and this represents the age of the demographics in each of those places. So we can see it's mainly made up of young people in Manchester, like you and me. And on the other side there, you can see in the rural areas, it's more densely populated with older people. And that's true in the south as well, but we don't really want to talk about them today. And we can see this growing internal migration here, and this is the future. So we've just seen the present population, and in 2043 there, the dark blue bars are rural and coastal areas where we can see increasing concentrations of people over the age of 75. So we have an aging population who are more likely to live in rural and coastal areas. The other thing that we're seeing increase is comorbidity and complexity. Now, as physios and you training as students in this profession will understand the training that we do in multiple body systems, in the varied parts of the system that we can work. We are really well placed to manage complexity and deal with complexity, which is a good thing considering where the population is going. I don't know why I'm pointing it at the screen. It's not really working. So we can see here, as people age, the more bars they have, which essentially is more comorbidity. So as people age, we are seeing increasing amounts of comorbidity in the population. So we have an aging population who are increasingly getting more and more conditions as they age. And we can see that over 75 is higher. Some of them with 6 long-term conditions or up to 6 long-term conditions. We're not in the dark with these, so we are seeing emerging clusters of disease. And again, we are really well placed to be able to manage and deal with these. So we can see here a third of patients with COPD will also have depression and also have osteoporosis. So if you're seeing a patient, or if any of you have been on placement and have seen patients with COPD, how often are you looking at whether they've got osteoporosis or other conditions? We're set up in single condition silos at the moment, whether it's MSK, neurology, respiratory. We're going to have to change that moving forward. Again, here there's a 24% higher risk if you've got osteoarthritis, that you'll also have cardiovascular disease. That goes up to 70% if you have rheumatoid arthritis. We're seeing things that are clustering together that we have to deal with more effectively. It's been mentioned in a number of presentations today already, but we have rising health inequality, whether that's to do with worklessness, housing, access to green space, use or access to technology, socioeconomic background, which we know is affected or more disproportionately affected for those from marginalised backgrounds or from those with protected characteristics. There's significant work we need to do here. We know that those who live in the poorer communities have more years lived in poorer health. We have to make inroads in these areas. We can see here, post-COVID, this is the difference in years between the least well-off and the most well-off in the 4 countries. So 19 years in England, 20 years in Wales, 23 in Scotland, and 14.5 in Northern Ireland. Massive differences in years lived with healthy life. And we can see this affects comorbidity. So the ones to concentrate on in this graph are the green and the purple. So you can see all the way through the age groups, the difference between the best off and the worst off has a significant impact on how many comorbid health conditions they have. You're more likely to have comorbid conditions if you're from a poorer community. We know the bottom fifth from those of deprived areas are twice as likely to have an MSK condition, twice as likely to have a respiratory condition, and 4 times as likely to have a mental health condition. We know where care happens in the system at the moment, and we're talking about this shift into the community, and there's a bit of a disparity here between what we hear and what we're told, because if we look here, and I know the numbers are small, but the blue boxes are where care already happens in the system, and it's predominantly GP appointments and predominantly in the community. So actually, a lot of healthcare already happens in primary and community care, but when we look at the funding, and this is what needs to change, here primary care in the middle there, that's in billions, is nowhere near social care and nowhere near prevention. This is the big one. So acute trusts get 80 billion a year, community trusts 4 billion. So where the majority of care is happening, where patients want and need to access care, is not being funded in an equitable way. So we need to see a significant shift there. So what? And I think I've blabbed on for too long now before I go to questions. So we've got a growing proportion of older adults, particularly over 75, and we're going to see that grow in over 85. We've got a higher concentration of those populations in rural and urban, rural communities, rural and coastal areas. We know that comorbidity and complexity is increasing, not just in the aging population, in lots of other populations. Complexity is becoming the norm, and we need to understand how we can deal with that, and we're really well placed as physios to do that. And we know that health inequality and diversity in the population is on the rise. So how are we going to deal with that as a group of professionals? So we need to change the what, where, and how of care, and I'm going to go over to my panel to talk about that first. But what I'm going to do first in this first round of questions is just ask them to introduce themselves and tell us a little bit about their career to date so we understand where they've come from and how they can get there. Physio is a really varied career, and I want to get a really good sense of the different paths it can take you. So if I start with Neil, please.
Thank you. Great to be here. Really nice to see everybody. My name is Neil Langridge. I qualified 29 years ago. I now work in a health sciences university, but my background was pretty much all the way through the public sector. I'm a musculoskeletal physiotherapist. I worked across the MOD and the NHS. And I studied a number of different universities to get to where I wanted to get to. I ended up as a consultant physiotherapist for 10 years, working across a community trust, looking after about 7 or 8 different hospitals, small musculoskeletal teams across orthopedics, pain management, and physio. I actually got into physio really about 3 days before the course started. Unfortunately, I didn't do very well at school, and found my way having to redo things and found my way getting into physiotherapy. I think my silliest memory is the fact that I woke up on the Monday when I'd gone to London for the course starting and realised I didn't actually know where the university was because I hadn't actually been there. that was not a very good starting point for me, but I did actually arrive and get through it all. And my most enjoyable experience as a physiotherapist was as a junior physio, working, looking after the ankylosing spondylitis groups, taking the hydrotherapy groups and the gym groups. That was probably my most enjoyable time.
Verity?
Lovely. Hi. Yeah, lovely to see all your faces here today. And what's really reassuring is it looks like the future of physiotherapy is really bright. From the quality of questions and comments that people have put through and the quality of the abstracts that were presented, it really is inspiring to see. So thank you for that and for your enthusiasm. So I'm a consultant physiotherapist. I work for Lancashire and South Cumbria, managing a long-term ventilation service. So my job is very varied. I work in the community, so doing home visits and seeing patients across the whole of Lancashire and South Cumbria. I work in the hospital and I work clinic-based as well. So I'm very lucky to have a very varied job and a job with lots of autonomy. So I lead this service jointly with our consultant medics, but we absolutely steer the direction of that service, and there's lots of really exciting changes. I've also been very, very lucky to have been supported in my own personal development, both within this job and previous job. So I qualified from Manchester in 2001, which feels like 5 minutes ago, but is literally a lifetime for some of you ago. I did my general rotations, spent about 2 years working doing general rotations, and I think that's really key because you need to have a really broad foundation for whatever specialty you go into, because there is such a crossover. You never just meet patients with one condition, do you? So having that broad basis is really important. I then worked in a number of temporary posts across the UK, which actually allowed me to work in lots of different services and to really understand how different teams and different services work. And that's helped me through my career. I worked in New Zealand for a while, which again, working in a similar but different health structure, has given me a lot of experience. I then went into respiratory was my passion, so I went into quite a broad respiratory rotation. So I was again able to work in a mixture of different settings, delivering different aspects of respiratory physio, including some time doing a research post for a year, which was brilliant. I then went into a specialty role, setting up a weaning and long-term tracheostomy ventilation service in the community, and actually seeing what it takes to look after someone who's completely ventilator dependent with a tracheostomy in the community, and the lack of infrastructure around them is really eye-opening and really makes you change your practice. And then I've been in my consultant role for 3 years, so that's been my journey so far.
Thank you, Verity. Esther?
Lovely. Can you hear me? Do I need to turn on the microphone? Sorry. Great. So I'm Esther Clift. I'm currently a consultant practitioner in acute frailty, working on the Isle of Wight, setting up an acute frailty service from scratch. My career is somewhat more varied than the others. So I knew at the age of 12 that I wanted to be a physiotherapist and work in paediatrics. And that is what I did. You can see the basic blurb from all of us in the bio, in the magazine or online. So I'm not going to go through my basics. But I've had a hugely privileged career in a variety of that. So I ended up doing paediatrics, worked overseas in East Africa for 10 years, went with 2 children of my own, came back with 3, and had taken a 10-year break really from physio, and came back in thinking I was going to continue with paediatrics, but also had a family who wanted me a little bit more around, having uprooted them from a feral outdoor life to a very contained British life. I had to think of a different way of doing it, and so I was invited to join in with a new nurse-led unit for older people. And that sort of was a springboard into a whole different way of thinking. Of course, holistic care for paediatrics and the variety that Gemma described so beautifully this morning does translate into older people's care. Very different, but actually there's some real synergies. And I think that's really true for all of physio, is that there are synergies into all sorts of different aspects. So you don't have to know where you're going to stick with where you're going to stay, I think, would be my career experience. And from then I did a master's in gerontology, and then had the great delight of running running multiple services, mostly focusing on older people, but then had the opportunity to do the consultant training that was pioneered in Wessex, so 3 years of training, which included undertaking a doctorate in clinical practice, where I think some of the stuff that Lisa was talking about in terms of communication really picked up, and being able to understand how poor in some ways my communication was, because one of the best learning mechanisms is feedback. And when you're in a training situation, people give you feedback, and patients give you feedback, and that's definitely the best way to learn. So I've been working now with older people for 20 years and have absolutely flourished and really enjoyed the experience of being with older people, listening to them, listening to what their needs are, and then applying all of my physiotherapy skills to enable them to flourish in whatever short stage of life that they have left. So I'm going to be the frailty advocate today, this morning. You're not going to hear of much else.
Nadine.
Good morning, everybody. Thank you very much for having us. My name is Nadine Adonis. I am a clinical specialist in neurology. I work at a London teaching hospital, Imperial Healthcare NHS Trust. I'm actually an internationally trained physiotherapist. So I started my career and I did my training in Cape Town, South Africa. And then I decided, well, I needed to have a little bit of a break, perhaps come do some traveling, and then did some locuming and decided, well, this is not bad, might stay. And then I've been here for 20 odd years. I've been a physiotherapist in this country for a very long time. My junior rotations were done in South Africa, so a lot of very varied rotations, going from A&E perhaps to community. So sounds very similar, but the conditions we saw were very, very different. And then coming over to the United Kingdom, I specialised in neurology, so looking at and following patients from acute all the way to doing community jobs as well. My current job is at a specialist centre for a rare disease, and patients that come and see us come from all over the United Kingdom. So I'm generally up here in Manchester every couple of months, in Birmingham and in York, doing clinics at different hospitals there, as well as doing a clinic in London 3 days a week. And what I can say from physiotherapy and a physiotherapy career so far is that, yes, it's varied, but you need to look for some of the opportunities that you don't necessarily get elsewhere, and perhaps some of the opportunities that you think, oh, I'm not sure I want this one. So in terms of me and my career, that's what I've done, which is why I work in rare diseases at the moment, and I've been doing lots of research, so I lecture at UCL, and then been trying to get grants to push some of the physiotherapy evidence-based practice forward. So that's me.
Thank you, Nadine. And thank you, panel, because we are on time, which is amazing. So before I ask my next question, I do have a wager with another CSP staff member that in my session there will be the most interesting questions at the end. So get your thinking caps on about what you're going to ask, because we want to leave plenty of time for that. I'm particularly interested in controversial questions. So my next question is, given the context that I gave at the start, over the next 10 years of these wonderful people's careers, where should they be placing their energies, effort, development, interest to make sure that they are having a fulfilled career, but also serving the population of the UK in a really meaningful way? So I'm going to go to Verity first.
I thought you were going to say that. So I think first and foremost, find your passion. If you want a long career in healthcare and physiotherapy, you've got to find what motivates you, because whatever your passion is, you will be able to sculpt it in a way that it can serve the population, because we are massively under-resourced within healthcare services. So if you can find your passion, you're more likely to be able to drive those changes forward. Saying that, although you need to find your passion, you do need to be thinking about the direction that healthcare is going. So I'm not going to talk so much about elderly medicine. I know that's going to be very much Esther's focus. That is obviously a huge expanding area, and one that we all need to be mindful of. I'm going to talk about my experience and what I'm seeing and where the gaps are. So I work in a long-term ventilation service. It's a regional service. One of the big gaps that we see follows on from Gemma's talk. It's people young people coming into adult services who have huge complexity. So these are young people, often with neurodisabilities, that have often been served fantastically by paediatrics with an amazing support network around them. Then they get to 18, 19, 20 and beyond, and that support network falls away. And what you're left with is just this big abyss. So notice that those young people are there with neurodisabilities, maybe with coexisting communication issues, with learning disabilities, and look for ways to serve them. We have to move away from condition-focused services. So, for example, I run a complex secretion service as part of our overall service. There is support out there. If you have COPD, if you have bronchiectasis, if you have CF, there is a route in for support and chest physio and pathways. They all exist. If you dare to have a neurological or a neuromuscular condition, that means your breathing muscles are weak, your cough is ineffective, you may have a scoliosis. No respiratory service generally will touch you because you don't have a respiratory condition. So we have to challenge and we have to move away from that mindset of this is a condition-focused service. Our service needs to serve the population. So we need to think about how do we get our skills and how do we develop our pathways to meet the needs of everyone rather than it being very, very condition-focused. And I think a lot of that comes from funding. It's much easier to obtain pathways and funding routes when it's condition focused. So I think we have to make sure that our voice is heard, that we're speaking and engaging with commissioners, with our business managers, and you know, with all our stakeholders really, both acutely and within community settings, getting our voice heard and shouting about those individuals that currently don't get as much of a look in. So my big push would be think about those underserved, and what I'm seeing is people with complex conditions that that don't have services to meet their needs, particularly the complex young adults, particularly people with learning disabilities. So that is an area that can really drive your passion, and it's hugely rewarding. You make such a difference to those individuals' lives, so that's where I would encourage you, so please follow along.
Thanks, Verity. Adine.
So I would agree with Verity. What we're seeing coming through, especially in our service, so because we're a national centre, we see everybody from within the United Kingdom who is diagnosed with a rare condition. The sad thing is it takes our patient cohort about 7 or more years before they actually come to our service. In the meantime, they've spent that 7 or more years going to their GP countless amounts of time. And when they come to us, and I ask our patients this quite frequently, why do you still come here? Because we'll see them lifelong. And they say, you're the only place that actually looks at me as a person, as a whole person, not just the condition that I'm being referred here for. So I would say, and echo what Verity said, is think laterally, think about the whole patient, think about population health, think about general health. Your patient will have all the things that Ash has spoken about. So think about those things when you are mainly looking at them from their respiratory perspective, or in my case, from a neurology perspective, because those patients will get colds and flus, they'll get COVID, they'll develop in outpatient caseload, or they develop bronchiectasis, for example, etc. So it's to say that when you do your general rotations, do them really well before you decide in terms of which speciality. When I did undergrad teaching at Hertfordshire, we would see many a time students would come in with a very fixed idea of I want to go into this speciality. And then practically what that translates to is when they are not put in that rotation when they get to their job, it causes a bit of unsettlement for them, as well as for the rest of the rotation, because they are so focused on what they want to do. And so they don't perhaps get the best that they can from the rotation that they're in. So keep going with your general rotations. I know at the moment there seems to be this urge for people to want to get through the rotations as quickly as possible. And I would say actually take your time as much as you possibly can. Take your time, learn as much as you possibly can, and then apply that learning to every other rotation you go. So instead of saying, I'm in musculoskeletal at the moment, that's all I see, because you will get a neurology patient that has musculoskeletal issues. You will get a neurology patient that has respiratory issues. And if you bed down those really foundational aspects, you'll at least be able to start with those neurology patients who have those other areas. So keep it as broad as you possibly can for your juniors before you then go into senior posts.
Thanks, Adine. Esther.
Brilliant. I would have said exactly that, Adine, and you said it much better in terms of that general foundation. It's a real strength of our physiotherapy training. Don't lose that. Don't let anybody talk you out of that. And I think that is an absolute strength of the future of physiotherapy, because we need that specialist, generalist sense wherever you are. Having been able to manage that complexity as juniors means that you're much better placed for the rest of your future. So I would say absolutely, fundamentally, that general rotation, that really good foundations at the early start, really, really, really important. I think the second priority that I would say for physiotherapy for the future, and this is not in a particular order, is that clinical academic synergy as well. So most of us who are sitting here have an academic hat as well as a clinical hat. I often talk about a big C or a little c, a big A or a little a, and I would describe myself as a big C, little a. So I'm a clinician at heart. Certainly 80% of my time is clinical, patient-facing service development and quality improvement, and 20% of my time is academic research. And I think that synergy is really, really important, because we often find it difficult to articulate our research base, to evidence our research base, to be confident in a research environment. And actually, you basically just need confidence that you know your onions and you can speak about them. And that will give us a much better voice for the future, because I think we're missing opportunities because we're not articulating our brilliance. And so holding that clinical research academic line together really, really matters. And of course, I'm working on the Isle of Wight, the blue, dark blue blob at the very bottom of England. We're ahead of the curve in terms of the ageing population. So it is all about frailty. If you haven't learnt robustly about the ageing process and frailty measurement and interventions in your undergraduate training, you need to learn it fast, because the first patients you see, unless you go into maternity care or paediatrics, are going to have a degree of frailty. So you need to be able to manage that. And I think geriatrics is always a bit of a Cinderella service. It's always underfunded and it's always understaffed. And yet it is the absolute gold dust in terms of working. So I'm a post holder within the British Geriatric Society. We've got a whole campaign for the next year about Choose Geriatrics. It's a moot point, because even this week there was an article in the BMJ saying, should we change the name of frailty? It's really pejorative. Patients don't like to be described as being frail. No, nobody wants to acknowledge that they're getting older. That's the bottom line. Doesn't matter what we call it, people aren't going to like it. But we need to get on, we need to recognise it, we need to capture how we can do that better. And as therapists, we've got all the opportunities to intervene from a public health perspective, as people have already said this morning, from a prehab, from a rehab, and then even right up to palliative care. So we really, really need to grasp our expertise in working with older people.
Thank you, Esther. Neil.
Yeah, thank you. So from a musculoskeletal perspective, I think that looking back to look forward, we've driven down into advanced practice and specialism, and we've created a workforce that have become not only musculoskeletal specialists, but just one joint specialist, and that has to change. We have to flip that narrative significantly if we're going to have value to the society that we serve. So we are rehabilitation specialists, and I absolutely echo the rest of the panel in that we have to offer the expertise that our superpowered delivers for our patients, and that is across a number of multimorbidities and across population health and also health promotion. So as a musculoskeletal specialist, it's not about the diagnosis, it's not about the algorithm of pathway up to orthopedics or medical interventions. It's about the interventions that we can have that will make a difference to people's lives in and around their social and environmental situation. We are able to rehabilitate and hold on to patients. Now, the problem with musculoskeletal practice as it stands is that it's based on an algorithm. You move patients through a pathway. There was nobody really holding on to patients. GPs did it very, very well, but of course the challenges in primary care everybody is aware of. So somebody has to be a case manager for these individuals. They are moved on very quickly when things don't go right. So, well, it's not working for you, we better move you on to the specialist service. It's not working for you, we better get you injected or see the surgeon or get a scan. We know those medical interventions really don't hold much water in musculoskeletal practice anymore. And actually, if you think about the shoulder as an example, there are shoulder surgeons that are finding that there's not enough work for them, because actually, at the end of the day, it's not actually required in the vast majority of cases. So somebody has to step into that space and hold that case management. Now, before we moved into advanced practice and before we moved into working in orthopedics, rheumatology, pain management, we actually used to do that. We used to do it far, far better than we do now. And I think that narrative has to be flipped. But we also need to flip the narrative slightly in that we offer care within medical situations, medical scenarios, medical units. We have to move into where the population is. We have to offer our services where the population doesn't normally access services. And we need to be quite brave around that. So when you are looking at service redesign, or if you're part of any of those service redesign, you've got to look around the room to decide who's making those decisions. Because in many cases, it isn't the right decision makers that are in that room. These are the people that maybe buy services or finance services or commission services, but they're not the people that actually utilize them. So be a champion for your population, because musculoskeletal practice has gone in one direction, and now I want to see it a far more greater breadth right across the population that we can help.
Thank you, Neil. Great answers there. And we heard a common thread there, not much disagreement, which is not my favourite thing. Verity will be happy. We heard a common thread there around the kind of broadening of skill, rotations, the need for breadth. Just out of interest, how many people in the room already think they know what area of physio they want to go into? Hands up. Some very tentative hands. I've got one of these in the front row as well. A few. How many people have no idea? Not far off equal. How many people didn't understand the question? No, I'm not going to answer that. That's that. Good. Okay. So before we get... last question now, but before we do, get those questions brewing, because we're going to have plenty of time for questions from everybody in here and online. So my last question to the panel is, and we have plenty of time for this, so you don't need to rush your answer, but what do you feel is the biggest shift we need to see in physiotherapy over the next 10 to 20 years? I will allow more than one biggest shift. And I will start with Neil.
Again, I'm going to talk through the musculoskeletal lens, and I think some of the biggest shifts we're going to see if we take clinically, that actually the vast majority of musculoskeletal conditions are managed really far more effectively with good psychological, cognitively informed behavioural techniques. And actually the physical side is probably far less than we'll even imagine. And there are studies that are regularly showing the impact of intervention, such as communication, the way that we manage goal setting, the way that we manage people in their own lives and their societies and their communities. And we can only do that through good psychologically informed practice. So although we're described as physical or physiotherapists, actually, if I was to do my training again, I would move it significantly into more psychologically and communication-based treatments or practice that informed the physicality of some of the interventions that we offer, rather than the other way around. Where we are at the moment is that we offer physical treatments that are informed by some of those practices. That, again, for you in the future is to actually challenge that, because we're rapidly becoming aware that most of those, the only effectiveness of those treatments is if we apply good psychologically informed practice. And I guess my second real, if I was allowed to.
You can have as many as you like.
Oh, okay. Big change is really addressing health inequalities and doing that really well, but also waking up to the fact that I guess it's an unearthed or unknown quantity, and I don't know if we're set and ready. there's a willingness to go in and say, we need to address this and try and balance things up. But how are we going to do it? And how are we going to actually achieve equality and equality to access and do it really, really well? And I think the leaders of tomorrow who are in the room are the folk that will, I really hope that happens, because I think that the question's been asked in my working practice, but there certainly doesn't seem to be the answers available just as yet. So I think that's the other big shift, I think, in terms of population-based health medicine.
Thanks, Neil. Adine.
Know your data. So a lot of the time when we are looking at MSc-related projects, for example, for students, we look at the data that they hold within their service, and it's very patchy. So know your numbers, know your facts and figures, know what it means. Ask those uncomfortable questions about who is missing, who is supposed to be coming to the service, why do we have so few of X, Y, or Z? Understand what health inequalities means for your population in the areas that you serve. Look at the wider landscape, know your research. And it sounds easy to say know your research, but as physiotherapists, we are evidence-based. And as Esther and I were having a discussion earlier on, the evidence for a lot of our practice may not always be as robust as we want it to be. But that's fine. Know what it is, know where it is. One of the other things, a lot of the time, either students or physiotherapists come and ask is, what can I do differently? So as chair of the Association of Chartered Physios, we have started to run more research-orientated webinars and fora for people to come and talk about research, get their toes into research. And what I would urge you to do is keep that research thread all the way through your clinical practice. It can only serve you when you're having uncomfortable conversations with the rest of the MDT about whether it is to discharge a patient or where to send a patient or how physiotherapy can or can't help a certain patient, etc. So think about that as you go through your career. Try and get involved in research from as early as you possibly can. It strengthens your clinical practice. The other thing for me is listen. So the previous speaker emphasized that, and I will emphasize it again, and as has the panel. Your communication with your patient is going to be of utmost importance, and it's the first couple of words they hear when you introduce yourself to them. That then sets the tone for that relationship you are going to have with that patient over however many times you see them, both as an in or outpatient. And so it's important to think about hope. It's important to encourage patients to do the best they possibly can with what they have at that point in time. Please, please remember, your patient is a person. They're a patient by virtue of where they are and the service they're connected to. But they are people with lives, with families, with hopes and dreams and work and all the rest of it that comes with it.
Thanks, Adine. Verity.
I'm sorry to disappoint, but I don't disagree with anyone so far. So I've got 4 things. The challenge is trying to remember all 4 when I'm talking and there's a spotlight. So firstly, the first thing is slightly on a tangent. What we need to think about for the future of physiotherapy is actually as employers and managers, how do we retain our workforce and how do we retain more of our workforce in the NHS? And a lot of that is actually noticing what's happening across other careers, and we have to allow people to work flexibly. We have to allow people to have flexibility in their jobs about where they work, having the opportunity to work from home where that still serves the population that they look after, because that helps us maintain a work-life balance. And it's hard working in the NHS. There is stress and there's a lot of pressure. And to balance that, actually you need to balance work-life. So I live in Liverpool, I work in Preston. I could not do my job if I couldn't work flexible hours to manage the commute and if I couldn't work some days from home. So that's what will keep me in that role, the fact that my organisation understands that. So I think we have to recognise that as employers. The other thing I think we need to recognise is there's a lot that can help us take things to our patients through digital expansion. So we talk about this and we utilise it to a degree, but we have still got so far to go as a profession and as a healthcare service. The fact that we still don't have joined up health records is criminal. You know, there is the ability to do it, and yet we can't manage to do it. My service, because we cover a huge geographical area, we do a lot of virtual appointments. We have modems on our patients' ventilators so we can see data from them. We've been doing that for years. We have virtual appointments. A lot of our training resources are online, and obviously a lot of that was driven through COVID. But there are a lot of services where that isn't being done to the extent it could be done. And even within our services, there are barriers to that. So we have to challenge and really use kind of digital access to reach the patients that we can, but also recognise that not everyone has got that digital accessibility or literacy. So we absolutely need to make sure that our focus isn't just on that. And if we are using digital platforms, that we make them as accessible as possible for everyone. The next thing I wanted to think about really is, as I said, we have to think about being proactive rather than reactive. If we are going to serve our populations moving forward, as physiotherapists, we are really well placed at driving those health messages and getting in early, whether that's to schools, to young people, within workplaces, to think about kind of the basics, isn't it, of you know, and getting the message out there about dangers of, you know, whether it's recreational drug use, whether it's obesity, whether it's vaping for young people. We need to spread that message and get that heard before it's too late and people are too far down the system. Particularly around obesity, I think we're very, very well placed to get that message out there, and actually for people that are obese to be part of those obesity services so that we can show them how they can access just a very basic level of mobility, but really with the goal of getting them meaningfully active again, as we know that's a really important part of a weight loss journey. And then I've now forgotten my fourth one.
Don't look at me.
I know. I meant to write it down. And I think otherwise it is, like we said, it is very much about thinking about how we make our services fit for purpose to serve our patients rather than us just following individual condition pathways.
Thanks, Verity. I'll go to Esther, and if you remember your fourth, Verity, come back to me.
I've just written something down because I thought I'm going to forget now because I get very excited. I think the challenge really for physiotherapy is finding and owning our space. And I think I often hear people apologising almost for who they are and where they stand. And we just need to get away from that. So I've got a C for confidence, actually. What's the future of physiotherapy? Being really confident. And I think having heard the student abstract presentations, we can be confident of our data because we know it and we can use it, but somehow we're still apologising for it or not using it as robustly as we need to. So really to be confident and to be confident of our capabilities as well. You know, I'm constantly having to remind people that as physiotherapists, we come out of university with a diagnostic capability. It might not be an acute abdominal pain, but it is the beginnings of diagnostic of something. That's what we learn to do at university. And yet still we're being sort of pushed back into a box, saying you've got to go back through some learning to be able to understand how you can handle the responsibility for managing a diagnosis. We do that as undergraduates. I think the personalised agenda, Neil's talked much more about that psychological element, but the engagement and the concordant conversations that we have with goal setting, we also need to really claim that and be confident in that. We do that as undergraduates. We know how to do that. And all of these things, of course, are feeding us into being brilliant handlers of the complexity that is looking after older people and managing frailty. So frailty is that domain between people growing older well and growing older less well. So those extended years of life, but with no quality. And that's where we sit and where we can completely have massive influence. And I think I'm having people asking me, so what would a physiotherapist add into that? Because nobody's told them up to now what a physio could add in. So being really, really confident and capable of expressing ourselves. And I think the other thing is that curiosity, which goes with the data and the research, you know, and asking the question, well, why not? Rather than waiting for permission to be given to be in a particular place. So working, of course, with the older population, working with people who are living with frailty, but also using all of our superpowers as a physiotherapist to engage at that level is what matters. And having a really confident voice that you know where you are and you know what you can do with it is where we need to go.
Thank you. And thank you to everyone on the panel for those answers. That's all the questions that I had. So we're going to throw it open now to the room. I can see Sundeep's already got a hand up online. But it doesn't have to be a question. It can be a thought. It can be a point you want to make. So it doesn't have to be a question. Sundeep.
There are quite a few comments coming in online. But the first question is, what are people's thoughts on physio and OT combined skill set for future working? Some services, it is a complete split, particularly in the rural locations where mixed skills could prove beneficial.
Great question. Who wants to take it?
Jumping in to start. So I think absolutely we need to combine skill sets. I've got a really good example of this. So we have a service in our region, which is a regional tracheostomy service, and they have kind of delabeled themselves. So it consists of a consultant nurse, a speech and language therapist, they've got an assistant practitioner and a physiotherapist, but actually they've all dropped their professional roles as such and have very much combined their skills so that they can go out and see a patient in the community and they can do the basics of many aspects of the job. So they're all prescribers. There is overlap between the speech language and the physiotherapist and the consultant nurse, and they've learnt each other's skill set. There is a recognition that there's sometimes the need for a kind of super specialist skill set, so they will then defer to their colleague. But it's all about actually one person going out, seeing that individual and serving the individual to the best of their capability. So I am absolutely all for trying to share and learn from each other and some merging of the skill set while still recognising when then to refer to our colleagues for that extra specialist input.
Thanks, Verity. Any thoughts from anybody else?
Yeah, I'm going to agree. Sorry, Ash, I know you want to fight, but I'm not going to fight. Particularly for people living with frailty, people want the person in front of them to be able to deliver what they need. So we need to have a broad skill set, but we also need to know our scope of practice and our level of practice, so where we need to go to seek help. And it is all about a team, so it's knowing who can intervene at any particular level. And there is a lot of synergy in terms of all of those things. But I'm already thinking, so I will pick a bit of a fight. Why does the tracheostomy service have to have a consultant nurse leading it? Both of the jobs that I've taken as consultants have been advertised as consultant nurse roles, and I've said, why is it a consultant nurse? Why can't it be me? And in both cases I've been successful. So I think we can flip that as well, that we don't have to sit in our box, and we can push the boundaries a little bit.
Thank you, Esther. Anybody else? Thoughts? Questions from in the room? A few hands up. I like it.
I'll try and keep my question brief and not too vague. So just for some context, I've been a sports therapist for 10 years, and over that time I've been running my own MSK clinic, and over the years it's kind of become some sort of an outpatient physio clinic in a way, seeing lots of kind of generic people come through as well as athletes. As a sports therapist, I've kind of realised that no one knows what a sports therapist is, and I got tired of explaining to people what it is. It's not just massage. I've placed myself as kind of an educated personal trainer or a budget physio. Obviously don't market myself as that, but so I've stepped across to physio, and I've realised that the situation is kind of the same. We're in general a lot more educated, but no one really knows what physio is. So the definition in the dictionary is a person qualified to treat disease, injury or deformity by physical methods such as massage, heat treatment and exercise. So my question to the consultants of 20 plus years, can you have a hash at giving your own definition of what a physiotherapist is, or what physiotherapy is?
Oh, I like that question. It's screaming Neil to start with, so I'll go to Neil. But thank you for that short question. It was excellent. You don't know Jack Chew by any chance, do you? No? Neil.
Well, thanks for that. That's great. I don't think I can offer a definition, so I'm sorry to disappoint you. But what I will comment on is that the profession moves so quickly and offers such extension and advancement in roles and capacity and change across the system that actually defining it is quite difficult because it moves so darn quick. So going back to what the general public think, yeah, of course, you think physiotherapist, you might think of somebody running onto a pitch with a bucket and sponge. They might think massage, they might think exercise, and that's fine, because I'm going to have a conversation with the patient, because actually I'm going to sometimes change the way that I present physiotherapy dependent on the patient in front of me. There'll be certain patients of let's say a certain generation that will want a certain way to be spoken to and will want care provided or presented to them in a certain way. So I'll shift what that definition is, and it has to be malleable. The next patient that comes in, how am I going to present physiotherapy to them? Well, I'm going to present it, let's understand them, and as we work through the consultation, hopefully at the end they understand what I'm offering, and what the collaboration is, and what the plan is, and what the management is. And that should be for them, their experience of seeing a physiotherapist. But that will be different from every single patient. So to define it in one go, I hope it's not too slopey shoulder my answers, but to define it in one go is really, really difficult. A, because of the pace of change, and B, because we serve everybody that's different when they come into your clinic or however you meet them.
Thanks, Neil. Anybody want to stab at defining it? Anybody else?
Always game for a shot. I've had the chance just to think a little bit while Neil was answering, and I think any healthcare professional, I think, would struggle these days to define themselves in a box. But I think that our superpowers or our specialist skills are in our actual personalised. Adine talked about holistic care, our communication capabilities, and I think we're really good at that. So I've just scribbled down that we're highly skilled healthcare professionals with a specialist capability in delivering personalised, goal-specific interventions to aid recovery. I'm happy with that.
I like that. Let's all clap that. Does that work for you?
Yeah, thanks. And I love Neil's way of saying it changes depending, but yeah, person-centered goals and patient-centered goals depending on their needs. Fantastic.
Before we move on, as a physio of the future, I'm going to put you on the spot a little bit now. How do you want to define it?
In a similar kind of way, but I do wonder if we need more. We're so varied. Maybe we need to embrace and celebrate chest physio. I'm a chest physiotherapist, or I am an acute physio, or MSK, and almost not completely separate inside of everyone, but start getting some understanding of the general public going, right, I'm going to go and see this type of physio. And that could also help doctors and medical professionals help us understand, or help them understand what the physio in front of them can do.
Yeah, I think that's great. And just before we move on to the next question, the public do generally have a pretty good understanding of what physio is, or that physio exists. So in England, for example, we have a really healthy pipeline of physios for that reason, because the public understand that physio exists. They might think of it, as Neil says, as the person who runs on the sports field. That makes it a double-edged sword, because people recognise it and they want to do physio. So, for example, we had 20,000 applicants in England for physiotherapy for 4,000 places. That's not the same for all of the other professions. So it's good that physio is recognisable, but what it's recognised for, we might want to define and change.
If I could come in for a second.
Of course.
I think one of the things we need to think about is what the unique selling point is that we bring. What do we bring to the table, and how is that different from everybody else sitting around the table? And as Neil said, it's ever moving and ever changing. So perhaps something to think about as we go forward.
Can I add in as well? Because, so I'm a very proud physiotherapist. I sit here as a proud physiotherapist. But actually at work, I describe myself as a consultant practitioner. So that's an interesting concept, mostly because I'm a prescriber, so I sometimes describe myself as a physiotherapist who does drugs. That doesn't always land so well. But I think in a context where physiotherapy in my older population is in a box, somebody lying on a trolley in the emergency department, I don't need somebody with a damp sponge who's going to make my sports injury better. What can you possibly add? So I have found it to be a bit of a barrier, which is why I use the practitioner title rather than, because my expertise is frailty. But it is controversial, and I am really open to discussion further about that with anyone who wants to pick it up, because it is an interesting, because I find it difficult to describe myself. So I'm absolutely with you, but I can give a really good definition of what physio is.
I knew it'd be hard to control it once it got going. Go on, Neil.
I just wanted to add one bit. It's that some of my real stark memories of introducing myself, particularly working, when I first worked into orthopedics 25 years ago, working with the consultants, is the patient would come in and I'd introduce myself as, I'm Neil, the physiotherapist, and I thought I was seeing a consultant. I thought I was seeing a doctor. But that has really changed. And we have really shifted things. And patients, from my experience, are interested whether you're competent, capable, safe, and nice. If you do those four things, those four things are assured. The vast majority of patients don't really mind. They're interested in their experience of your care, professionally irrespective. And that's been the shift that I've seen, that the drop of the sort of shoulders when they realise they're not seeing a doctor, that isn't the case so much anymore by a long way.
Can I also come in there? So I completely understand what you're saying about how you introduce yourself. I wonder how readily patients identify with understanding what that role is. So one of my clinic days is a consultant-led ventilation clinic, so they could see me or a medical consultant. I am very, very careful to always introduce myself as a consultant physiotherapist and correct the patient when they say, "Thank you, doctor," only because I'm also very aware that patients need to know who they're seeing. I need them to understand what the boundaries are within my roles. There are lots of things I can do very, very well. There are also limitations to my practice. So I need to be very transparent with that. I also work with a lot of physician associates. I don't know how much understanding you have of their roles or what you know about it, but X went absolutely nuts about it, because actually, and I actually came off X for that reason. There is a lot of anger really out there, particularly not with all, but between some medics and the BMA and the GPs around how they view physician associates. I work with a fantastic physician associate, but I have to make sure I protect him in his role, and part of that is he needs to be very clear with introducing himself, what his role is, and that he is supervised and supported by a consultant. That can be me or a medical consultant, but yeah, I do think it's important that people understand who they're seeing and maybe what the boundaries are, both to protect ourselves professionally and to make sure people have an understanding.
Brilliant. Absolutely. Can I chip in again?
You've got 30 seconds and I want one more question.
So I think interestingly, I think we're conflating what patients think, because as Neil said, patients want to know, are you competent? Can you do what I want you to do? And if not, are you going to find somebody who can? Absolutely. And what the rest of our healthcare professional colleagues, so the whole Twitter PA stuff is led by the medical doctors who are feeling disenfranchised. I had a really big conversation with Age UK, because it matters to me what my patients think. And I said ask them to advise me what are old people saying about their healthcare providers, and nobody is concerned about the titles or the roles or whatever. What they want to know is exactly as Neil says, is this person in front of me competent? So it's absolutely right that we need to be clear about our own professional capabilities, and we're describing that, and the patient does know exactly who we are. And in my work situation, I wear a uniform that's different to the doctor's uniform, although I carry the doctor title, but it's not on my hello, my name is, as does Neil. So it is really complex. Most patients, it would take me 45 minutes consultation to explain what my capabilities are. What they want to know is, can I do it, can't I? But it's around our working with our medical colleagues who are very clear about what our code of practice is, what our capability is, and how we're managing that. And so I think we need to be really clear about how we're describing what we're doing for patients, but also that we're keeping our medical colleagues. And part of it is that, the medical colleagues wanting to maintain their own expertise, and they, I think, would struggle harder to describe themselves than we just have now. So it's going to be a long-running conversation, but we need to be really clear about what we're capable of.
Thanks, Esther. Got time for one more question. It could be a yes/no answer. That would be great. About a minute. Heads.
Hiya. So I've just started as a physio, as a band 5, and I absolutely agree with what you guys are saying. I think as we specialise and we get more experience, there's so many windows and so many doors that can open and what we can go into. But I find initially a lot of my job is discharge planning, to the point where there's been discussions on should we do more of that at uni and less of the manual handling training, because you'll learn that as you go. Personally, I don't think so. I think it's quite controversial, but I just kind of wanted to get you guys' opinion on should we do more discharge planning, because especially in acute in the hospitals, that's the majority of my job at the moment. Less physio, more discharge.
Who wants to go? Short and sweet, if we could.
Go on, quick.
Quickly, no. So in order for you to understand where you need to discharge the patient to, you need to be able to assess and rehab to see what the capabilities are in order to understand, you know, they need to go down X, Y, and Z stream. So no.
I would say absolutely no. Unfortunately, it's a product of a system which is completely broken. We shouldn't be the ones that are trying to fix it. We've got better skills that need to be used elsewhere, so our skills need to be further upstream. We need to be allowed to rehab. We don't want to be discharge officers. Somebody else needs to step into that space. But unfortunately, I think that's the only space that we've been allowed to occupy in quite a lot of acute trusts. So fine, get out, go and do work in the community, support people, prehab, rehab. Don't be doing that. Absolutely not.
I'm going to be challenging. So I think we need our curriculum to be fit for purpose. I think there is an element of our job, not that we should be discharge planners, we shouldn't be advising about care, but what we should be thinking about is we need to be front and centre in the community. As demonstrated on Ash's slides, there's huge amounts of funding into the acute sector where we need to be putting our MDT services into community hubs. We need community hubs that can support our patients, keep them out of hospital, keep them out of hospital, get them out of hospital quickly when they're admitted, but then with the ability to continue to deliver rehabilitation in a community setting to keep them independent and also to be able to work effectively. I think we work brilliantly as MDTs when we're all sat in the same room, which works well in an acute setting. It's more challenging in the community, not because we're not capable as working as MDTs, but because you often don't know that person. You're not in a room with them. And actually, if you took the model, which kind of the NHS plan for the future is, and our current government are looking at to create these community hubs, that would naturally lend itself to that. So I think we do need to think about it in the curriculum, but not as discharge planners, but as enablers and understanding how we can link in with community services to keep people out of hospital.
Thank you. Neil, last word or words? Just a no will do, I think.
No.
Good. Excellent. Thank you to the panel. Really great answers. Sorry we rushed through that, and sorry I've stolen a few minutes of your lunch. What I would say is we talked about quite big things here, the future of physiotherapy. There's complexity, there's aging population, there's the way we train, the way we define ourselves. It is hard, it is difficult, tough. You are the people that are going to have to do it. I would think less about what we think and start thinking more about what you think and what the future of physiotherapy should be. Enjoy your lunch.